So just so everyone is aware, this session is currently being recorded. And just to be mindful of everyone's time, I just have the pleasure of introducing Dr. Barron. He's been involved in addiction medicine research and education for over 40 years. His current focus is on MAT or MAT training for health providers, and he focuses on the opioid crisis. He served as a medical director for a number of addiction treatment programs, which includes Horsham Clinic, Malibu Beach Recovery Center, as well as Claire Matrix Foundation. He taught addiction medicine to healthcare graduate students, which includes physicians, nurses, as well as graduate students for the past 40 years. And he's also been a doping control officer in the world of elite sports since 1983, where he still continues to be active in this field. So while he was deputy clinical director at the NIMH, he was appointed and served on the drug-free workplace legislation senior task force under President Reagan. So we're very honored, and we have the immense pleasure of having Dr. Barron speak to us today. Dr. Barron, I will be sharing the slides shortly, and you can just let me know how you want me to navigate them.
Okay, if I could just say, when I say next slide, if you can go on, that would be easiest. So can we go ahead and get started?
Yes.
So actually, we need to go back to the first slide.
Yep. Can everyone see the slide?
The ones I'm seeing, it looks like half the slide has my yeah, that looks a bit better.
Okay, we can navigate it this way if that's okay.
Very good. That's great. Well, welcome everybody. I know it's late afternoon back in New York, and it's just afternoon here in Los Angeles. First thing I have to say is I want to thank all the PsychSIGN leadership for inviting me. I've done, I guess, maybe my fourth or fifth time I've been honored to be able to present to you, and I'm really excited about doing it. Although I got to be perfectly honest, I am not a big fan of the virtual. I know this is our new reality, but I would much prefer for us to be together and be able to get a hot or a cold beverage afterwards. But this is better than not doing it at all. The other thing I need to say is that introduction actually is one that was for a large addiction program I worked for, and that actually doesn't really reflect so much what I do now. I have been very much involved in this and still involved with addiction, but most of my work has actually been in the area of global mental health and in the area of sports concussion. So one of the things I'm going to recruit some of you on as we get to the end of this presentation is a number of international groups that I work with and that I chair, that I've actually brought in medical students to get involved. These are international projects. We've had some of our students at Western University, where I'm currently the provost at, out here in Pomona, California, and then we have a campus up in Lebanon, Oregon. And our students, in fact, I think the president-elect of PsychSIGN is one of my Western U students, so I'm so very proud. But really, it's just a great opportunity to see where psychiatry kind of has been and where it's going. I've had the great pleasure of being able to teach psychiatry for a number of decades now. And the reason I get so excited about it is I truly, in my heart of heart, believe that there is really no better specialty in all of medicine than psychiatry. And I'm not saying that to be politically correct, but I think by objective data, this would come out as far as lifestyle, opportunities, everything from basic science. You know, we talk about translational being bench to bedside. Well, it's really not bench to bedside. I've written some papers saying that true translational is molecules to Main Street. We need to expand it to what do we know at a molecular level, and what does it mean beyond the bedside, but really Main Street. So getting involved with public policy. And I think what we've really seen in COVID-19 is how really prevalent this is. We need to understand what's going on at a molecular level, developing the vaccines, but where it really matters, and we're seeing this now globally. I was on emails just this morning with colleagues from Turkey and from Egypt that I do a fair amount of work in. It's not just what we were able to develop with the vaccine at a molecular level, but what we're able to do at that kind of that public policy, public health, getting people to understand that you need to get the vaccine. The tragedy that we're seeing now all over the world, and certainly in the US, is that we have the answer right there in front of us, but we need to convince people to go out and get vaccinated. And we've seen some tremendous advances across the country, certainly in Los Angeles. We're seeing, that people maybe not having to wear their masks if they're fully vaccinated. But I think what we're going to see, and what I'd like to talk about for about the next 25 minutes or so, is a subspecialty area of psychiatry. One of the things I find so exciting about psychiatry, and just by way of full disclosure, I'm a third-generation psychiatrist, and my son works in mental health at CHLA here in Los Angeles. So I've kind of grown up in the field. My grandfather was a psychiatrist, was actually friendly with Sigmund Freud before he started getting into some of his issues with some of it. I have a signed picture of Freud in my office, even though I'm not a psychoanalyst, but I'm proud of the stories. I remember my grandfather telling me about what Freud himself said, the real basis of psychiatry is going to happen more in the molecular level. Now, this is obviously the world's most prominent, the father of psychoanalysis, but people forget that he actually was quite a brilliant lab scientist in his day, given what was going on. So I think your interest in wanting maybe to become a psychiatrist just shows your insight into really what the opportunities are. Psychiatry as a specialty keeps growing. This past year was our biggest number of students going into it. And I think a lot of it ties into what I'm going to be talking about a bit today. And that's this kind of and I put it in quotes new because it's really not new, but it's really emerging as almost like a subspecialty. And that's this area of lifestyle psychiatry. And this isn't something that, that we're going to see as, like a just brand new field. But what it is, it's a field that demonstrates where a real understanding of biopsychosocial really plays into health. We've all heard the quote a million times, there is no health without mental health. Well, it turns out the biology of what goes on in most illness, not just mental illness, can really be traced back to the stuff that we do in psychiatry, and that's dealing with how kind of people think, feel, and behave. So I'd like to give you an overview of this. Just say that this is actually an emerging subspecialty. A good colleague of mine up at Stanford, Doug Nordsey, serves on an international panel that I chair, and we're actually developing lifestyle psychiatry at a global level. What we see is that this is not just something for the US, but in fact, when we look at global mental health, again, an area that I've had a lot of interest in for quite a number of years, it really is about understanding what we can do to improve mental health and psychiatric diagnosis and care in countries that sometimes don't have the resources that we have in the US. We look at the low and middle income countries. And one of the things that I find very interesting is medical students in the United States getting an opportunity to learn how to do kind of more with less in the way of resources, an opportunity to see how much we have to offer within the field of psychiatry and integrated mental health and behavioral health. So that's what we're going to be talking about today. I also wanted to make sure that we had ample time for questions and comments. You guys sit through, and ladies, I use guys in a nonsense, not just for the men in the world, but both men and women, and any other preference. But it's really about questions that you have, and I want to share some thoughts with you, but I'd prefer to I'd like to take most of at least half the session on questions, comments that you have, because you hear lots of lectures. As a medical student, you spend your whole bloody day listening to lectures, whether they're synchronous or asynchronous. So I'd rather have this be kind of plant some seeds, keep it at a level that maybe creates some interest, and then have that whole second half be related to what your thoughts and questions and comments might be. And it doesn't have to be restricted to lifestyle psychiatry. I know in past PsychSIGN meetings I've done, we've talked about kind of cues about interviewing. So I've served as a department chair in 3 different departments at the NIH. We had a graduate department of psychiatry and behavioral health with FAES. I was the chair at the Temple University School of Medicine in Philadelphia, chair of psychiatry. I served as vice chair and interim chair of psychiatry at USC here in Los Angeles. But I've also been a training director when I was at USC for a brief period of time. So I feel like I'm fairly well qualified to make some comments about questions you might have about interviewing, kind of where the field's going and what you might want to do to secure your spot in this terrific and growing field. Next slide, please. So when we talk about lifestyle psychiatry, it really is exactly as it sounds. We've talked about lifestyle medicine and what that means about teaching patients and their families, but really in society and public health officers, because it really goes beyond that. Again, instead of, translational medicine should go molecules to Main Street. Think of Main Street being more in that public policy. And again, it's so relevant to what we're dealing now with COVID. How do we get people? How do we get young people now to go out and get vaccinated? And, we've all seen some of the strategies. It's not about having, just Tony Fauci. By way of full disclosure, Tony and I were buddies. We used to jog together. When I was at the NIMH, he likes to jog, and I was at NIMH, and he was at his institute. He started about a decade before. We used to go out and jog. We sat on the NIH bioethics committee for a number of years. He's a brilliant guy and just a wonderful, wonderful role model. It kind of pained me to see what he went through up until January, but I think things are going well. But what we see is lifestyle. So we might have all the data, but if we don't get people to go out and get the vaccinations, if we, and before the vaccinations get people to wear the masks, even though we might have had the answers, it wasn't making a big difference. Having the super spreader events, the tragedy that we're seeing in India, actually was probably in many ways related to a cultural event that was a super spreader event. If you look back to the 1918 pandemic, the Spanish pandemic, but we actually learned about this even back then. So there were two US cities, some of you might have heard this, that Philadelphia, my old home city where I grew up and went to medical school and taught there for many years, Philly back in 1918 had a big event when it came out, and they decided to not cancel the event, and they had it anyway. Seattle had a big event at the same time, and they decided to do a kind of essentially what we would consider now a lockdown. Well, needless to say, the event in Philadelphia that was not canceled led to be the ultra super spreader event and led to a lot of pain and suffering within Philadelphia, which then went up and down the East Coast. New York, as you know, only 80 miles from Philadelphia, and Seattle essentially had very little. So we've got the knowledge. But as we know in psychiatry, it's not just about the knowledge, but it's about your attitudes and your behavior. So for example, if you know that smoking is not good for you, we have all the data, but your attitude is, well, I got to die of something and it helps me relax. So what the heck, I might as well smoke. And then the behavior is you continue to smoke. So even having the knowledge in and of itself doesn't make a big difference. And we see this with COVID, and we see this in a lot of areas. And COVID has really acted as a magnifying glass. We all know that we shouldn't be stressed out. We all know we should go out and get some exercise. Yet how many of us, and I include myself in that, unfortunately, we get up in the morning, we sit in front of the computer, we're looking at Zoom calls, we're doing lectures, and we're not really doing the things that we know we should be doing. So lifestyle psychiatry really, I think, will really come to the surface now in a way that it probably wouldn't have as quickly were it not for what we're going through with COVID. So that might be one of the silver linings to this very dark cloud that the whole world has lived under for the last 15 months almost. So again, it impacts lifestyle behaviors. So knowledge is great, but what we really care about most, quite honestly, when we're practicing clinicians, whether we're an internist or a psychiatrist or fill in the blank, is how people behave. So if someone says, you know what, I don't believe in this whole thing, I think it's a lot of baloney, it's just another virus, but even though I believe all that, I think I'm still going to go and get my shot. Then what do we care? So the behavior in many ways is what translates into all the things that we would be looking for and looking at as psychiatrists. So within the domains of lifestyle psychiatry, we know there are a couple of things that, again, we hear about all the time, but what we've seen and what I've had a chance to do over my career is get a chance to actually study some of these things. So yeah, it's great to say that exercise makes you feel good, but does it really make a difference? Well, the reality is, yes, you all know you're being taught this, and this has been relatively recent. I'm talking about over the last maybe 10, 15 years, where we've gotten some good data, good brain science data, as it were, neuroscience data, to demonstrate that, in fact, things that fall into these domains of lifestyle psychiatry are, in fact, can be measured biologically. We see an old colleague of mine, Gary Small, who used to be out here, who's published a lot of work and done work looking at the role of exercise. I've published some work on the role of exercise as a treatment modality for substance abuse, for depression, for anxiety. And what we can do is measure changes in the brain. You can measure BDNF, you can measure a whole host of things. So the domains that we've known for a while, we now got some better science that will allow us to maybe even convince people a bit more. The mind-body practices, we've heard a lot about yoga and Tai Chi. The one that you're seeing a lot recently, in fact, there was an article that just came up on if you get your news through Apple, this morning's Apple thing was talking about mindfulness. And again, this isn't anything that's particularly new, but what we're demonstrating now is these relaxation techniques have a real biological basis. Now, what I've been able to demonstrate, and a number of colleagues of mine we've worked with looking at cancer patients, is that exercise is good, but what's really better is enjoyable exercise. And we did a couple of small studies looking at this. And if you think about it, if you love to go out and walk, it doesn't take a whole lot of convincing to say, well, you should go out and take a walk. It's a good excuse to do what you want to do anyway. If you can't stand to walk or to jog, even knowing it is not likely to change it. So one of the things we need to keep in mind in lifestyle is one of the most important factors in doing something that we know could promote health and well-being is it enjoyable? And in fact, there's very good data to show now that if we do things that are enjoyable, they're actually much more health promoting. And we can measure this. If you look at the Enigma work, again, a very fine, probably the finest neuroimaging group in the world out of USC, who really have, global studies looking at the brain from a neuroimaging perspective. This has really been demonstrated visually. So meditation, mindfulness, sleep. We always said, well, it was good to get sleep. There was an old myth that, well, some people only need to get 3 or 4 hours sleep. Wrong. I've been involved with sleep studies earlier on in my career. And the reality is that individuals need, usually it's about minimum of about 7 hours. Can you get by pulling an all-nighter before your anatomy exam, and you can actually have a little bit more resilience to lack of sleep when you're younger. As you get older, it gets less. But the reality is the brain needs usually about 7 hours for just about everybody of good restful sleep. Now, sleep is something that's important that we need to know in lifestyle psychiatry. It's not just the quantity, but it's the quality. It's just like if we look at calories, you need 2,000 calories, they used to talk about that. Well, if you're getting 2,000 calories from drinking beer all day long, that's probably not the same as 2,000 calories from having a nice fish diet with some fresh veggies and a nice fruit. So sleep is the same way. It's quality over quantity. And the big question we talk about is, how do you measure quality sleep? Do you have to put somebody in a sleep lab and spend thousands of dollars and get, no, not at all. It's actually quite simple. We've done it in villages in low and middle income countries. You ask somebody, do you feel rested in the morning? If someone says, yeah, I get up in the morning and I'm feeling pretty good, they probably had reasonably high quality sleep. If they get up and they say, yeah, I was in bed for 8 or 9 hours, but I'm just completely toasted in the morning. I need, 2 cups of coffee and dunk my head in ice water to wake up. Then they probably didn't have good quality sleep. And quality sleep, you can measure. And what we know is fragmented sleep, which sometimes, if you've got an exam the next day and, you're waking up every 2 hours because you don't want to oversleep. Oh, did I remember to study this? Or did I, that fragmented sleep is not quality sleep. And it turns out that the brain needs that level of sleep. You literally see more distance in between neuronal molecules in the brain, and you can flush out things that, toxic chemicals that develop during the brain. So Nora Volkow at night has done some really fine work, a number of other folks, but sleep is really important. Eating habits. Now, again, they do see some variation. Some people are just not morning people. They always say, breakfast is the most important meal. Well, it's true that you probably don't want to have a big fat-laden meal an hour before you go to bed. But there are some people who just aren't big morning people. I have folks who say, I just don't like sitting down and make, so I say, buy a protein bar, go to Costco. They're not that expensive. Wait till they go on sale. So you get, 10, 12 grams of protein. They're relatively healthy. They have those chocolate drinks, the protein plus. So I think when we talk about eating, it's eating habits. What is not good, as we know, is much of the fast food diet. The comfort foods tend to not be so comfortable when it comes to our overall health. And actually, it plays some role in psychiatric issues as well. So, again, I don't want to get into each of these in too much detail, but stress management clearly near the top of the list. We now know from COVID, it's been just a global stressor, and even people who don't have, an axis one with the old DSM axis one, we don't even have that DSM, we don't have the 5 axes anymore, but stress management. I don't say stress, because we do need to, stress is always there. And it's been very stressful, since, March of 2020. But how do we manage our stress? And the stress of being a medical student, hey, I want to be around my classmates. I want to, this has been a real stressor for virtually everybody, but I think for students particularly so. So what can we do to help manage our stress? Making sure we take time to get away from things, to turn our brains off a little bit. To not obsess over it. I know one of the things that I'll share with you that I found myself doing is if I had 5 or 10 minutes during 2020, I was putting on CNN, and I was, and all it did is get me more upset. It's so like, what's the administration doing today? And, how are we screwing things up with, these messages? And, I saw the look on my old colleague's face, Dr. Fauci, and I was afraid I was going to kill him. I mean, Tony's I think he turned 80 this year, but he went through a very stressful time because he's a quality scientist and was trying to do the job to the best of his ability, but was really highly stressed in doing what he knew he wanted to do and needed to do. So learning stress management, teaching our patients that, but also learning what's stress reducing for us. Some people listening to music, just putting something on and kind of tying into the, to some of the mindfulness background is allowing yourself to stay focused in that moment. Don't have your music on and be thinking about what you should be studying or who you should be calling, what you should be doing, but literally allowing yourself to be completely immersed in the moment. Listening, if you go for a walk, just really sometimes don't try to multitask. Sometimes multitasking can be stress inducing, but just enjoy the scenery, the plants, the flowers, the sights, the smells, the sky, but really kind of staying in that moment, which is one of the hallmarks of mindfulness, is actually quite effective as a stress reducer. We talk about life balance, the importance of relationships. This has been a big issue that we've really learned a lot more about during COVID. It's not the same being on a Zoom call and seeing somebody's face as being with them in person. Yesterday I had a chance to go on campus and meet with my provost team in person for the first time in quite a while. And it was just so great to see them. I mean, even though masks we had our masks on, but we just sat together, and that human interaction. And I know for you all, your friends, your colleagues, this is the thing that I'm so disappointed with, and I'm so happy that we're finally hopefully getting out of this, is what I loved about medical school. And then when I went to graduate school after that was being with my classmates and discussing things and learning from them and just, blowing off some steam together. So life balance and relationships are a key issue in lifestyle psychiatry. We talked about smoking, drug and alcohol use. I don't think we need to spend much time going over that. Next slide, please. So interestingly, as we've talked about the integration of lifestyle medicine, and I think this is what we're going to see in the practice of psychiatry going forward. So I was trained, my initial fellowship was in consultation liaison psychiatry. I worked in general medical hospitals because at that point, I wasn't interested in working in a psych hospital. I loved the interface between psychiatry and medicine. And so here in a minute, I've been able to do that, and something that some of you might want to consider. It's really about this biopsychosocial perspective. And again, there's a lot of data that shows that inflammation, I'm not talking about, you cut your finger and you get infected, but kind of a central inflammation, the role of the inflammasome, not only in cardiovascular and GI disease, but a very, very important role in almost all forms of psychopathology. There's some really fine work that's been done over the last 15, 20 years on that. We've talked about lifestyle factors, not only initiating disease, but increasing risk factors, exacerbating existing disease. So it really plays the whole role from primary to tertiary care. And we've already talked about the importance of lifestyle psychiatry and lifestyle medicine with when people are stressed and anxious. We're talking a lot now in my generation and even a little bit older than me, people really worrying about dementia and Alzheimer's. They thought it was all genetic. Well, it turns out that the epigenetics are probably even more important than the genetics. And by epigenetics, I'm sure you've all studied those and learning about that. It's about kind of how we change the genome based on lifestyle issues. So really lifestyle psychiatry and lifestyle medicine is actually rooted in the whole concept of epigenetics. Next slide. So is it a subspecialty? It's not yet, but it's getting close to there. So you're seeing programs like the Stanford program, again, run by Doug Nortsey, a good friend and colleague, just came out with a new book on lifestyle psychiatry. They're starting a program up there. I think other programs. I think what you'll see is lifestyle psychiatry will be similar to what we saw in consultation liaison, which is a recognized subspecialty of psychiatry. Like I said, I did my first fellowship out of residency was in CL psychiatry. I co-ran a CL service, and I ended up running the CL service at the NIMH when I had my research lab back there many, many years ago now. But I think it's something that really, even if it's not a subspecialty, it should be a part of every psychiatrist. It's just one of those things, they say like, well, learn to play the piano if you really want to be a good musician. It's kind of a fundamental thing. But I think understanding lifestyle psychiatry, and I think it really is good for the field, because what it's done is I've actually seen it lower some of the stigma that still exists in many cultures, many ethnic groups. It's getting a lot better than it was even when I started my career. But the idea of understanding psychiatry from a lifestyle perspective, I think has gone a long way and has helped quite a bit in lowering stigma and then allowing people to address this as kind of a medical illness, not as a flaw in your moral fiber, which we certainly see in the area of addictions, but also in other areas of psychopathology. Next slide, please. So I wanted to just share with you, so the way psychiatry is set up kind of administratively, as it were, is each country kind of has their own psychiatric association. So in the US, we have the American Psychiatric Association. It's the largest in the world. I think there's over 40,000. It's one of all the subspecialties. It was actually the first of the medical specialties to develop their own. Benjamin Rush, back again in Philadelphia, started the American Psychiatric Association in the mid-19th century. But there is something called the World Psychiatric Association. Now, what that is, that's the combination of all the countries. I think we're up to 160 countries now. Their country psychiatric association all form to the WPA. So the APA is part of the WPA, but obviously the largest and one of the most influential because of the resources that we have. The WPA is made up of sections. There are quite a number of sections, and each section has a section leader. So I'm actually the section chair of the World Psychiatric Association section on medicine, psychiatry, and primary care, something very near and dear to my heart. I was trained as an osteopathic physician, very proud of that training. And there was a very strong focus on primary care medicine during my medical education. So it's allowed me to kind of bring this in. This is one of the fastest growing of the WPA sections. I've actually brought in a section of what we call a project within our section dedicated to looking at medical students. I want to actively go out and get medical students who are interested, to get them involved in potential projects, to get them to know, psychiatric leaders from around the globe. So for those of you who are interested in this, fire me an email and we'll get you involved. And again, it's something that I think you'll find fun and interesting. And global mental health is such a fascinating area. I know I've been very fortunate that I spent some time with the State Department in the Middle East now 35 years ago, and I was a two-time Fulbright winner. So I got a chance to do a Fulbright and stay very active in the Fulbright movement. So there's wonderful opportunities. Lifestyle psychiatry is not an alternative. I mean, some people say, well, I'm either going to choose lifestyle, versus medications or psychotherapy, and that's just dead wrong. Lifestyle psychiatry really integrates all forms of intervention as is appropriate. It was getting me very upset not that many years ago, where people were thinking that all psychiatrists did were to write prescriptions. And why that was is managed care. It's more expensive to have a psychiatrist see a patient than a therapist, a non-physician therapist. So they would have the therapist see, and the psychiatrists were only being used to write scripts. And I think that was a terrible thing for the field. It would be like a cardiologist saying, well, no, I'm only going to give, beta blockers. No, the cardiologist takes care of the heart. Psychiatrists, we take care of people. So lifestyle psychiatry is an important part of a puzzle that goes into the assessment, evaluation, and treatment of folks with issues with psychopathology. Again, I've done a lot of work over the years in sports psychiatry. It's a very strong area of interest. And what we see is sports psychiatrists take care of psychiatric issues in athletes. It can be a primary or an adjunctive treatment. I think it's just, again, it's part of the puzzle. We would never tell a diabetic patient, well, just get the right dose of insulin. No, we talk about stress reduction and weight management and diet, and the appropriate management of diabetes is all of those in the proper balance. And again, the important role of dealing in resource challenge settings, this low and middle income countries, and many parts of the United States have nowhere near enough psychiatrists, particularly child psychiatrists. If you want to feel where you will always be in the highest demand possible, become a child psychiatrist. There just aren't anywhere near enough, and probably never will be, unfortunately. Next slide, we just have a few more, and then I'm going to get into the questions. So what are some of the opportunities for medical students? Again, this is what I think PsychSIGN should really be all about. One of the things I'd highly recommend, and I know I did this as a medical student when I went through my clinical rotations, was let my, whether I was on a medical or a surgical rotation, let my attending or certainly my resident that I was working with know that I had an interest in psychiatry, that I wanted to learn as much as I could about medicine or surgery. But oftentimes what I found, and again, this is a long time ago, but I don't suspect it's changed that much. My son attended PCOM back in Philadelphia a number of years ago, is that when I was on a surgical rotation, I ended up getting, well, we got this medical student, why don't you go talk to the patient? So I got to learn medicine or surgery or the subspecialty areas, but I also got a chance to do a lot of, I guess, what was early CL psychiatry. So use these concepts as a good student physician when you go through all your various rotations. Explore expanding peer-supported emotional wellness programs on your campus. With COVID, a lot of schools have gotten peer-supported groups, which turn out to be very effective, where you're not going to the student mental health center, but just groups of students. I'm sure many of you are probably already doing this, getting involved to help out yourself and your fellow classmates. We've had students at Western U, at Comp, where I am, who one of our students got a grant from the American Psychiatric Association to develop mental health awareness programs for the local high school. And she and a number of her classmates have done really an outstanding job in reaching out to the community. And I know she's really enjoyed it. And I have every confidence it's going to make a big, when she's going up for her residency application, it's going to allow her to get probably into her top choice, because it demonstrates what she's done. And we've got some papers written for that. So it's an opportunity you can do as a student. Discuss opportunities with your local and national psychiatric interest group. I mean, within your club, what opportunities are there to get involved with projects? Whether it's with WPA, APA has a very strong and vibrant medical students group. You can go to the meetings for free. I was just elected a couple weeks ago to be the chair of the Global Mental Health Caucus for the APA. And one of my agenda items for the next 2 years that I'll be chair of that is the same thing, as we're going to be reaching out to students to get involved in some of these global mental health projects, because you are the future of our field. So it shouldn't be about what the old timers want to do, but what can we learn from you? And I say this not to be politically correct. There's a lot we can learn from you, particularly with technology, but what works for you, so we can work together. And I think these are real opportunities to get involved. And as I mentioned, the WPA section, in addition to, we have the International Society of Sports Psychiatrists, which is largely in the US, which is a subdivision within the APA. I'm on their board of trustees, and we also reach out to students. We've got a number of students who've been involved. And if you're into the sports interface, and not just elite athletes, but really sports, and even for the weekend warrior, just people want to go out for a jog, it's a good group to get involved with, and lots of interest in engaging students, but also being respectful of your time commitments. Job one is getting through medical school and doing as well as you can. So I think we have just 2 more quick slides. I want to get to our questions. Oh, yeah, I'm sorry. So the question, the last slide is just a couple of references. I know some people say, oh, where can I read a little more? These are just a few that I pulled out. I would highly recommend, and as you can see, they're all very, very recent. But I can highly recommend Doug Nordsee's book that came out with the API, the American Psychiatric Press, just a little over a year ago. But so there is a lot out there. And what you'll find is you probably have more medical knowledge than you need to even get into this. So I just wanted to put those up. So according to my watch, we have about 25 minutes. And let's just open up. I think we have about 45 on the call, but I don't know whether we want to do it through a chat. Chain, maybe you can do that, but as many questions, comments, it doesn't have to be lifestyle psychiatry. So the next 25 minutes are yours. And thank you so much for taking time on a Saturday as part of your meeting. And I look forward to getting to meet and know some of you in the years to come.
Dr. Barron, thank you for this beautiful introduction to lifestyle psychiatry. We really appreciate it. And we thank you for your time on a Saturday afternoon. So one question in the chat that was dropped, that was, did anyone get the chance to write down his email address? I don't remember seeing him earlier. Would you mind sharing your email address with the group?
Oh, in fact, why don't I put it into the chat right now so then everybody can get it? Yeah, I thought I had that on my slide, but I realized, see, this is the thing I forget to do now, because that's probably way more important than where I'm working is my email address. So let me put this on now. It's D Barron, it's just my name, D Barron at westernu.edu.
Thank you so much, Dr. Barron.
Hopefully that, did that come through?
Let me check the chat. I don't think it has.
Oh, let me type it in again to everyone.
Was that the email address you used to send me the slides? Because I can just copy. Oh no, that's Gmail. So there was a question in the chat.
There it goes.
Thank you so much, Dr. Barron. We see it, dbarron@westernu.edu.
Yeah. Don't forget the U. It's got to be dbarron@westernu.edu.
Awesome. Thank you. As for the question, please take turn to speak and unmute yourself and ask questions. I think that would be way more interactive than just me reading off the chat, if that's okay. So if you have any questions, please use the raise hand function, and then maybe Dr. Barron or I could call on someone to ask questions. Taylor?
Okay, thank you very much. I appreciate this session. It's been great, Dr. Barron. Thank you. Just to start with a quick comment, to PsychSIGN's credit, we have an international student group, and we're all we just right before this conference discussed international psychiatry for about 40 minutes. So I think we're all really interested. Just keep an eye out for some emails from us. But my question for you is something that I've had for a while about lifestyle psychiatry, and I'd really like your take on it. Were this a medical school lecture, or we had more general medical colleagues with us, and not like-minded, colleagues who are all kind of on the same page, I think a lot of them would be frustrated and say that lifestyle psychiatry is too amorphous or ephemeral. It lacks a rigor, either an implementation or approach. And I'm curious, how do you see lifestyle psychiatry being implemented in hospitals or outpatient practices in a structured, real manner, more than just in a more social policy? Thank you.
Yeah, it's an absolutely excellent question. And it in fact mirrors what happened with psychiatry. So psychiatry prior to the 1990s were designated the decade of the brain by Fred Goodwin, who was the head of NIMH. Fred hired me when I was a deputy clinical director there. But if you look historically, psychiatry was viewed as kind of this, it wasn't really science, it was kind of amorphous, and exactly what you're seeing here. Now, what happened to change that is when science started to get more directly involved with neuroscience, with research. The problem with psychoanalysis is it was basically, and again, like I said, my grandfather, knew Sigmund, they were all case reports. Well, everyone knows now a case report you can't even get case reports really published in decent journals anymore. So what you raise has been an issue with the field of psychiatry for probably 150, 160 years, but it's an excellent question. So the way you go after it is you use the scientific thought, you use studies. So you say, okay, we're going to do a study. We're going to look at it. And I did this with a group of cancer patients. I had a group of women who had breast cancer. We have a big cancer center. I was at USC for quite a number of years. And we developed what was, and I didn't even call it lifestyle psychiatry. We had a control group where they just sat around and schmoozed when they were in the waiting room. We had a group that was assigned a particular form of exercise. And we had a group who could choose what they enjoyed. and then we monitor it. We got a PCORI grant that we looked at that. And what we were able to demonstrate, and we had outcome measures, you know, kind of quote, more hardwired science. And we were able to demonstrate, is what I've been talking about, and most people for years, the women who were able to choose what they like to do did better on a number of biomarkers. I'm not just talking about, well, I feel a little bit better because I enjoy it. So the answer to your question is really a critical one. And it's really, I believe, one of the problems that if we don't address it, we run the risk of losing kind of scientific credibility. So what I think we do as a field is we say, we have a hypothesis and we test the hypothesis. And now we have some biomeasures that we never had in the past to really look at this. So this is, because otherwise people say, well, you know what, everybody knows that, but a good bartender will tell you, don't worry about, this stress, well, hopefully we're a hell of a lot more than good bartenders. But I think what you raise is an important issue for psychiatrists. If you're going to choose to go into the field, what I've done, so when I started in sports psychiatry many moons ago, it was like, what is it really? You roll out a pro athlete or an Olympic athlete and they give those. I said, no, that's what it is. So we measure, we do science. I do a lot of work in concussion. I've got a 5-year prospective trial looking at what's going on in the brains with mild repetitive brain impacts. So we bring that scientific model into it. And what we always want to do is demonstrate what are the outcomes. So as a CL psychiatrist, they always wanted to get rid of us because we couldn't bill for what we were doing in the hospital. Back then, the insurance, the internist could bill the surgeon, but I go in and do it. So, but what I did, I learned this a long time ago when I did my fellowship, way back now, is I was able to demonstrate how much money we saved. The patients who we had a chance to see got out of the hospital sooner. They were much less likely, we found this over years, to sue the hospital for malpractice. So what we have to do is say, it's not about telling somebody it's right, but how do we, quote, prove it using the scientific model? Not going in to try to sell what we're doing, but to study it. And it turns out the more you study it, the more elegant the studies are, the more provocative and the more demonstrative the data is. So now I do a lot of neuroimaging. I chair the sports section part of Enigma, which is the largest brain neuroimaging in the world. We now have very good data to demonstrate there's something goes on with DTI that we can measure with DTI and spectroscopy when you do repetitive brain impacts. That's a whole lot better than just saying something. So never forget the question you asked, but don't have that be a reason to not get involved. It's all the more reason to do the good science. And that's what I push in the sections I work with. Let's do good science. Great question, though.
Thank you, Dr. Barron. And thank you, Taylor, for that awesome question. So I believe up next we have Tim. They raised their hand. So Tim, you can feel free to unmute yourself.
Thank you. Hello, Dr. Barron. First of all, thank you so much for this talk. This has been amazing. It feels silly to say, but I didn't realize when you went through all the domains of lifestyle psychiatry, didn't realize all of my interests in psychiatry fell under a name, lifestyle psychiatry. I just thought that was what psychiatry all was. So it's so interesting to know that that's its own little section, and I really appreciate how you talked about it. My question actually is about bioethics. You mentioned really quickly that you worked at the NIH bioethics committee, I think, with Dr. Fauci, and so I'm actually pursuing my MA in bioethics right now alongside my DO degree. And I'm super interested in continuing my work in bioethics and working on an ethics committee in residency. And I just want to know, what has your experience been as a psychiatrist? What has your experience been in being able to apply bioethics, but also do that academic bioethical work if you have it all?
Sure. So first of all, lifestyle, as I said before, this should be a part of every psychiatrist. This isn't a subspecialty. It's like if you're a general psychiatrist, you still want to know about what went on in your patient's childhood, traumas they might have had. You don't have to only be a child psychiatrist. So I really believe, although I think this could become, as more science becomes available, kind of a subspecialty area, I almost had mixed feelings about that, because then it's like, well, I don't need to do that. Let's send them to a lifestyle psychiatrist. This should be part of the core, the core fabric of understanding and evaluating psychopathology, or even forget psychopathology. People who don't have DSM psychiatric illness. So I remember when I was at PCOM, I think we had one lecture on medical bioethics, and I was very interested in that because a lot of it had to do with psychiatry. We are the only specialty that can take away someone's civil rights. If you say someone is a danger to themselves, danger to others, or gravely disabled, in every state in the union, You know, in California, we called the Letterman-Petrie short. It was the same way in Pennsylvania, that you can hospitalize someone if they meet those criteria. So if you go into psychiatry, bioethics and medical ethics are a very important part. And if you do a residency, I think all residencies have, you know, a lecture or two. I got very interested when I went back to the NIMH. I had a chance because I was the deputy clinical director. The government paid for me to go back to Georgetown. Georgetown had an excellent medical bioethics program. A guy named Veach ran that program. So it really was superb. And I was appointed to the NIH Bioethics Committee, and that's where I met Tony and a number of other folks. So I would suspect now that there will be opportunities. I mean, one of the things we've been thinking about at my school, at Western U, is developing programs like online certificates. So you don't have to go get a degree, and one of the areas I'm particularly interested in is in medical bioethics. You know, can you force some, let's look at the vaccine situation. What are the ethical issues about someone says, I don't want to get a vaccine? Well, you know, this is not anything new. You know, go back to MMR and a whole, you know, vaccines have been around for a very long time, but they're core bioethic issues. And I think every medical student, but certainly in psychiatry, absolutely in psychiatry, this is an important part of what we do. And I think it gets into some of the lifestyle issues as well. You know, so there are some opportunities. I know the program I trained at was at Georgetown because I was living in Washington and I was working at the NIH. Superb program. I don't think you have to go out and you know, get a master's in bioethics. I did it because the feds paid for it for me. But I think just getting some of the core issues and the discussion. I know what I try to do when we do discussion groups with our residents, when I was involved much more with residency training, is we would always bring in that ethical question. You got an elderly person who doesn't want to leave their house, yet they're, you know, they don't quite meet grave disability yet, but the family can't take care of them. So ethical issues are oftentimes a critical component of what we deal with in developing an appropriate treatment strategy. So I would highly recommend, and when you go internationally, it gets very complicated depending on that. So I've done work in Saudi Arabia, I've done some work in Russia then you see how culture starts to, and government and policy plays even a more important role. I'll never forget one of the most stressful cases I ever had when I was a CL psychiatrist at USC many years ago at LA County. We had a Japanese woman who her husband was a high-level business person. She found out that he was having an affair. She had moved over here from Yokohama, was living in LA and felt very isolated. And long story short, she took her 3 young children, went out to into the Santa Monica Bay. Hopefully they would all drown, do the honorable thing. The only one that survived was her. So she was at LA County Hospital. And then, you know, should they charge her? And she was a patient that I did a psych consult on. And death would have been the thing that would have been most, you know, desirable for her. But the court systems had a hard time dealing with what was going on. I mean, she didn't want to kill her kids. She wanted to do the honorable thing because her family had been dishonored by her husband's behavior. So that's, again, you know, we struggle with that. I mean, Elizabeth Bouvier was, you know, the right to life. She was one of the patients I had a chance to do a consult on back in the day. And that became kind of a landmark medical ethics case. So that's probably how I got interested. I got to work on some really kind of interesting cases. So I think it's an important part of psychiatric training. And what I'm going to try to do over the next few years is now with online training is get some really kind of, you know, almost like a CME thing, but diving into bioethics, particularly in regards to psychiatry.
Thank you. I really appreciate you discussing those cases as well. So there was a question in the chat. Oh, I believe Jesse raised their hand.
Hello, I'd like to thank you for an absolutely wonderful presentation. I got to do a little bit of research at USC underneath Rael Khan. I don't know if you're friends with him or not.
I am.
So it's great to hear that. And I suppose this is only tangentially related, but it's of a lot of interest to me. And it's really blowing up in pop culture right now, is this kind of third wave of psychedelics in psychiatry. So I don't want to, you know, have too much of a leading question, but I'm very curious what you think about what's going on with this.
Well, it's a great point, and this is nothing new. I remember when I did my residency at USC way back in the day, started in 1979 when I was a resident there. So I was at USC for quite a while, and then went to Washington, and ended up back at USC for my second stint from 2010 to 2017, the second go round. But this has been, again, this goes back to probably even before the 60s, but it was very prominent in the 60s when the psychedelics, and there was a guy named Jolly West who was the chair of psychiatry at UCLA and was doing some really interesting work with psychedelics, psilocybin, and some other things. It was kind of the era, a remnant of the era of the 60s. Unfortunately, it had a pretty negative impact back then on psychiatry. Psychiatrists were viewed to be kind of weird, kind of hippies who were smart enough to get into medical school, and there wasn't time. And it gets back to the earlier question that I thought was, that Taylor asked, which is so good. And I think what we have to do is we have to rely on the science. If we get beyond that, then everyone has a viewpoint. I remember reefer madness, when I was a kid growing up, that was, but a lot of this had very little to do with science. It was about public policy. It was about, cultural norms. And I think what we need to do as psychiatrists is not allow ourselves to get caught up in something. We need to, and this is what Fauci has always done. Tony was always about, let's do what the science tells us. Let's not make up the science. Let's not bend to political. And that's why he was unwilling to do that, which is why it was, I don't want to get into a political thing, but literally Trump was killing him. I mean, it was just so against him because he is a scientist. And I think that's what we need to do. My belief is that there is probably something there. Now, what we need to identify is in what patient population. I mean, there are a whole lot of variables. I think when we start making these blanket statements like thou shalt not or thou shalt always, we run into problems. I believe we can learn a lot about developing new treatments by understanding if someone did get better, what was the mechanism of action? Do we need to have someone be, smoking weed, or we need to have somebody doing, ketamine? I mean, I did work with Hussein Imanji. We were looking at ketamine way back about a treatment for depression. The problem was Special K had a lot of issues, right? But we've learned that. So I think the answer to this is where we need to, as psychiatrists, and you as the next generation of psychiatrists, need to stay focused on doing the good science. Understand, I mean, if you think about it, what is chemotherapy? You give a patient poison, yet people don't think anything about that. So what I try to do is stay away from making personal value judgments about it. And what I'll say is, if there's data that it improves, what does it improve? Are we understanding, is it that, or is it that, there are other factors? So getting back to good clinical science, good translational science. And what I'm hoping is we don't end up throwing out the baby with the bathwater, either by saying it's great, everyone should use it, or by saying, this is craziness. I believe that there's probably some, I believe in my heart, there's some really good value there. But what we need to do is understand, what is it doing? Is it affecting the core inflammasome within the brain? Is it affecting brain connectivity? Are we seeing, changes between amygdala and hippocampal and prefrontal cortical connectivity? What's going on? Once we start to be able to answer those questions, then in that translational model, we can start to see, oh wait, is there a patient population where maybe controlled use of this might have a benefit? But the problem we've seen is claims that are made that turn people off, and there's no science behind them. Now, that's not unique to psychiatry, but we pay a greater price for that. So I think that's going to be one of the interesting challenges for any of you kind of wanting to get into a career in psychopharmacology, but understanding what is the mechanism, what can we do, and what can we, in the end, do to maximize how a patient, thinks, feels, and behaves in a kind of a health promoting mentality. But again, highly hot topic, a lot of political implications. And as I said at the very beginning of my talk, it's never just about the science. We have to have the science, but how do we roll the science out? How do we get people's attitudes and then behaviors so we don't have people feeling like, well, I just go out and, buy some drugs on the street corner and I'm going to treat my depression. We've got to bring it back to that science, health promoting, public health model. Again, great question.
Thank you so much.
Oh, sorry. Thank you. So we have time for one more question. I believe Morgan raised their hand first. I'm very sorry, Andrew. So Morgan, you can go ahead and ask your question.
Just real quick, if anyone didn't get a chance to get their question in, fire me an email. We can get on a Zoom call, or I'm happy to speak with you. I mean, this is the thing I always get frustrated with when I do talks. It's like, I'd rather have done 45 minutes just schmoozing with you, but I figured I had to show you that I did spend a little time putting together a slide deck. But anybody who doesn't get a chance to ask a question, either email me, I'm happy to call, we can do a phone conversation. I talk quicker than I can type, but I don't want anyone to feel like if you have an important question for you that I'm more than happy to get back to you and share whatever I can with you. So let's have the last question though, the last one for this call.
Thank you, Dr. Barron. My question is as a DO. I'm in training to be a DO as well. And I'm wondering if you utilize OMT in your practice or ever have. And then if or how you see OMT as a underutilized modality, specifically like affecting the not only mechanical model, but behavioral or circulatory models in psychiatry or lifestyle psychiatry.
Yes. So one of the things, and again, by way of full disclosure, things are a little different when I applied to medical school. So I applied to 2 medical schools, an MD and then a DO program, both in Philadelphia. And I was fortunate enough to get accepted to both of them. The reason I chose to become a DO is I was very impressed when I went through my interviews. Is the way the students were, the working together. I really liked the philosophy that seemed to really matter. You treat a patient, you don't treat an organ. And I was an athlete, and it was very consistent with me. So my dad was a DO, my grandfather was an MD. So I had I had a little bit of exposure to both of them, and they were both psychiatrists. So I went in to medical school in my med school interview saying I wanted to be a DO psychiatrist, and I wanted to try to promote the field, because oftentimes the psychiatric training, because there just weren't enough DO psychiatrists, was all that great. They were going to state hospitals. They weren't getting, there were very few interactions to do CL psychiatry. I mean, I hate to say it, but I was the first DO that USC ever took as a resident. Now that was a tragedy because that residency had been around for a long time. So it wasn't until 1979 that they selected it, to have a DO. And in response to your question, I believe there is a role. Now, just like psychiatry, the field of osteopathic medicine has had some of the same. There's been a lot of claims that have been made, but not the level of data that our allopathic brothers and sisters would rightfully like to see. AT Still, we go back, historically, his great-grandson, Andy Still, was a psychiatrist. They had the Still Hilthrin Clinic. So his lineage went into psychiatry. And really the first DO psychiatric hospital was his great-grandson, I guess it was, not great-great. So yes, I do use it, but I use it cautiously. Certainly if you have a patient who's got PTSD, right, you're probably not going to be doing that. And again, remember, I've been a sports psychiatrist, so I've taken care of half a dozen professional teams. I still work with pro teams in the Los Angeles area. I work with the IOC. I'm very heavily involved in sports psychiatry. And I can tell you over my career, I've been mainly in allopathic institutions just because that's where I trained and I had a research career. Although I've always stayed very loyal to the osteopathic profession, always tried to lecture there. But I've had many MD neurologists who said, Dave, can you teach me some of this stuff? And what we're seeing now with the residency, all residencies being combined, you're going to see more and more of that. I must say that I've been underwhelmed with some of the, they used to have something called, cranial manipulation. And I have to be perfectly honest. And again, I say this as a loyal and a proud DO who spent essentially my whole career in the allopathic world. The data on that to me it's not where I'd like it to be. I'm not saying that doesn't work, but I think we need to do better science. I think when you have, you need to have a sham group when you're doing something with manipulation, an active group. So I have used it. I still use it. I use it a lot in athletes because many of the athletes would much prefer to get some OMM as opposed to, me prescribing a med, which since I do doping control for 30 years, I'm very cautious about that. I think there is a role. I think the osteopathic philosophy has served me particularly well in the way I view not only my field as a psychiatrist, but as a clinician and as a clinical educator and as a clinical researcher, which has been the bulk of my career. So I was one of the people that really would go back. We had a guy named Nick Nicholas when I was at PCOM, who was one of the kind of one of the godfathers back in the day. And I would go in, I wanted extra training in this. And he said, well, wait a minute, you're going into psychiatry. I said, yep, I want extra training in it. So I would go in and, but particularly in certain areas, there's certain things I'll say I've not used much of, but I believe there's a role for it. And it's another tool in the toolbox. You know, you don't use every tool, but if you're going to use a tool, you better know how to use it properly and know when to use it appropriately. So my advice to any of the osteopathic medical students on the call is be proud to be a DO. I've been proud of it. I was proud when I was a deputy clinical director of NIMH, and I was proud when I did my, my Fulbrights, and I always had to put DO on my, but I was proud to be a physician. I was proud to have been able to teach allopathic medical students for many years. Very proud to be in that world. And what we should be most proud of is gaining all the tools we can to bring to bear to our patients and the research that we're doing. So, yep, use them, but use it wisely, use it in an educated way. Just like the we were just talking about, psychedelics. If we're going to use those, we better know everything we can about them and make sure the first thing we learn as physicians, allopathic or osteopathic, right? First, do no harm.
Well, thank you so much for your answer, Dr. Barron. Many people in the chat are thanking so much for your time and for having participated with us today, and really appreciate you dedicating this time this afternoon.
Well, it's my pleasure. I wish you all the best of luck. Be safe, be healthy. And again, I mean it when I say I look forward to meeting you in different venues as future colleagues in the years to come. But enjoy the rest of your conference. Thanks so much. Have a great day.
Thank you so much, Dr. Barron. Have a good one.